So hello and welcome to this special A+A conversation. My name's Hilary Worton and I'm Senior Vice President of Client Experience Optimization here at A+A. So my role here is to help translate complex healthcare insights into meaningful perspectives that support our clients in their decision-making within the pharmaceutical industry. Today, I'm really happy to be able to introduce Dr. Nicolas Blin. Dr. Blin is a consultant haematologist at Nantes University Hospital, as well as being an eminent clinician with several decades of experience, clinical experience. Dr. Blin, over recent years, has been working with our teams to help them better understand the rapidly evolving multiple myeloma treatment market. Dr. Blin, thank you so much for joining us today.
Welcome.
So today you've been working with our teams. Thank you so much for spending the day with us. We've been focusing on helping the sales and insights and therapy intelligence teams really deepen their understanding of the multiple myeloma market so that they can better support our clients. Just off the top of your head, give us some of your initial perspectives on overall impressions of the day so far.
So my first impression about this day are very positive. This is the first time I come here, even if, as you mentioned, I've been working with APLUSA for 4 years now, specifically on various topics, including multiple myeloma. I appreciated particularly the enthusiasm around my venues here. So I thank you all for your invitation. I had during the first part this morning was dedicated to this workshop on multiple myeloma to have an overview on the treatment of multiple myeloma in 2026, and I have many questions during this presentation. I find it to be quite interactive, and I found for people attending are interested in this topic and very involved, obviously, in this topic.
Great. Yes, there were some interesting questions, weren't there? Hopefully nothing too challenging for you. But I'm interested. I'm interested in your perspective. If you're advising healthcare market researchers in a company like A+A or in industry as well, market researchers working in multiple myeloma, what knowledge or perspective do you think for them as outsiders is most important? What do you think they overlook that is only, when you're working actually with patients? How would you advise them?
So I think the value of the market research society like you is probably to give, I would say, deeper perspective into the main points and the key drivers for us to make choices between different treatments. I treat patients with multiple myeloma on a routine practice, on daily practice, every day, many patients. But we discussed the clinical practice guidelines, European American guidelines, and they are only the backbone for I would say, the choice makers. But there is not only about those things. The patient profile, the patient related, the patient willingness to go to the hospital needs to be taken into consideration, and it's something which does not appear on the clinical practice guidelines. So I think this improvement might be a part of your different studies, and it's something which is not obviously described in literature, in published data anymore. I want to generalize a questionnaire, which can be developed by artificial intelligence tool, for example, which completely ignore this part of the decision-making process.
Yes, that's fascinating, actually. And it's something that we often really ask ourselves to think about. How can we really help our clients understand how clinicians like you are making those treatment choices for specific patients? And obviously some of it will be related to, the profile of the disease. Some of it will be related to the characteristics of the drug, but it's so complex and multidimensional. So for instance, and it's changing. So in your perspective, how would you say, if we think about treatment sequencing, how you choose between which drug comes when in that treatment, in the patient's treatment pathway, how have you seen that evolving in recent years?
So obviously we have a lot of innovation, a lot of clinical trials. We've seen the results in the last EHA meeting in 2026, the result of big phase 3 trials with bispecific, with various combinations, especially thinking about bispecific combined with anti-CD38, for example, or combination with IMiDs. And clearly for the bispecific markets are going to come earlier in this course. As you probably know, there are also some ongoing phase 3 trials trials underway in the first-line setting in both patients who are stem cell transplant eligible and ineligible. Obviously, the results are not being made public and are still under evaluation, but we might anticipate that probably those new combinations are going to give new possibilities to treat the patient more efficiently with a great level of efficacy, great level of MRD negativity. This is one of the most important surrogate markers in the field of multiple myeloma. And I'm very confident about the fact that we might integrate those bispecifics in the first line setting or in the second line setting, so that the vast majority of patients, I think, in the last, let's say, 5 years, will receive those agents earlier in disease course. That's what we do currently. This is also the same with CAR T cells. We are still expecting the reimbursement of cilta-cel in the second line, but I hope it will happen rapidly. And the majority probably of patients receiving a CAR T in the near future will receive it in either second line or third line.
It's fascinating, isn't it? That dimension of CAR T versus bispecific. And in your mind today, how do you decide whether you're going to pick a CAR T or a bispecific? How do you do that? What factors do you consider?
So this is something we've discussed during the workshop this morning. If we take a look at the response rate, obviously the CAR T cells are associated with a higher level of response rate as compared to bispecifics. However, when you take a look at the duration of response of PFS, the difference is not that wide, basically. However, we know that with the CAR T cell, we tend to obtain a greater level of depth in the response and great level of MRD. So currently, we tend to favor the use of CAR T cells in patients who are young and fit and who could receive either CAR T or bispecific. So the philosophy, the mindset currently will be to try to favor CAR T cells first, because this is a one-shot treatment, because even if the median PFS is not that superior to the one of the bispecifics, during that period of time, the patient does not have any symptoms, he has optimal quality of life. In younger patients, they can get back to work, they can forget a little bit disease, they no longer have any treatments, and they are doing very well. Even if we know that finally all those patients unfortunately going to relapse, and at time of relapse we'll have to proceed to consider the use of bispecifics who have demonstrated a nice level of efficacy also in patient relapsing after a CAR T treatment. In more elderly patients, a bit less fit, even if the age limit is not completely a consensus, but let's say that after the age of 80, or in patients with some level of comorbidities or frail patients, clearly CAR T cell won't be feasible and will be reasonable, I would say, due to the excess risk of neurotoxicity or CRS. So here we will going to prefer the bispecifics. And the bispecifics tends to be usually well tolerated, even into quite elderly patients after the age of 80.
And you mentioned something this morning, which I just want to come back to, about if you're thinking about bispecifics for a patient, maybe further down the line, you're actually having to prepare for that in treatment choices at earlier levels in order to preserve the T cells. Do you want to just share with us your perspective on that?
So yes, this is something which doesn't appear very well in clinical practice guidelines and recommendations, but in routine practice, this is something we take into account, because we know that in patients who do escape, who do progress, or who are poor responders under treatment of bispecific, we know that the T cell exhaustion play an important role. And if you have exposed the patient during multiple lines of treatment before the bispecific line, with multiple doses of steroids, with different sequences with alkylators, cyclophosphamide, and so on, we know that it will have an impact in T cell proliferation from T8 lymphocytes especially. And here we will be exposed to a higher risk of early relapse or even lack of response and refractoriness. So this is another reason why we would be tempted to try to propose those bispecifics in early line of therapy in order to prevent this T cell exhaustion and the T cell escape.
Yeah. Interesting, isn't it? So we're seeing the bispecifics, that increasingly the trials are moving them further forward in the treatment sequence. What about ADCs? ADCs now coming in at second line and more ADCs coming through the pipeline. What's your perspective on that and where that fits?
So this is another line of treatment besides bispecific and CAR T cells. They have studied even that some of them the development even earlier than the bispecifics. We have, even if we don't have more limited access in France to those agents, we had the early access program a few years ago, which had been interrupted. After all, it's another treatment option. I would say it's probably less efficient than bispecifics. If you take a look strictly at the follow response rate and PFS data, even if when you combine it with the, I would say, a good drug, either a PI or an IMiD, it might increase the level of response, the duration of response. And when taking a look at this duration of response in combination with, let's say, Worton one other IMiD, it might be associated with nice duration of response. So probably we would consider them in patients who cannot receive a CAR T and probably either not eligible to a bispecific or relapsing after the bispecific. There are another targets, different targets for those ADCs. There are also ADCs targeting GPRC5D, for example, under clinical developments, some phase 2 ongoing. So it might be another treatment option for those ADCs in patients previously exposed to BCMA, either it's a CAR T or a bispecific.
Right.
So it will come probably after bispecific or CAR T cells, but or in patients who cannot receive neither the one nor the other. But I think it could be an interesting treatment option to consider anyway.
Yeah. Looking forward, I mean, there's been so much activity in this space, so many tremendous advances actually in multiple myeloma. When you think how far we've come, where's this going? What's your perspective on, what's coming next? What's the greatest opportunity for the next generation of
So drugs, we have seen a tremendous level of innovation in the last 10 years. As I mentioned this morning during this overview, we have received more than almost 10 different approvals in the field of multiple myeloma in the last 10 years. So every one new every year, which is unprecedented. I don't have any other examples in other hematologic malignancies with this same level of innovation. I don't know in the future we'll have in 10 years from now, we'll have 10 to 15 additional approvals. There are obviously unmet needs, including with bispecific or CAR T cells, because some, unfortunately, those patients being to relapse to those new targeted treatment options. So we have new drugs under development and thinking about the CELMoDs, targeting the E3 subdomain, the cerebellum, which could be our night treatment options, maybe also in combination. We also seen some results from this EHAM meeting 2026 with a drug which is called mesictomide and in combination with carfilzomib. So it might be of interest in those advanced phase of the disease in patients exposed to the 4 major classes of drugs, including PIs, IMiDs, CD3 agents, and
a new class.
Yes, a new class. And there are obviously some subset of patients with very high level unmet needs, thinking about patients with extramedullary disease, EMD, or classical cell leukemia, both primary or secondary, who do systematically poorly with the altered genome outcome as compared to the standard risk patients. So,
do you see there being enough focus in that area of unmet need in terms of clinical development pipelines from the pharmaceutical industry?
I think that there are anyway quite a lot of clinical trials on some of those agents. I think pharmaceutical industry needs to understand that even if there is a tremendous lot of enthusiasm around the BCMA, GPRC5D agents, we don't need to forget, especially who do relapse after those treatments, and they don't have to abandon those stages because we see them in our daily routine practice. And obviously, we know that the situation is very difficult to manage. The number of treatment options is very limited with the ongoing available treatments. So I had one of the message to give will be, don't forget those patients who have been I would say exposed to those major classes of drugs, because they are still unmet needs.
Yeah, very true. So changing the subject slightly and coming back to, the work that you've been doing with us. So what motivates you to do that? Why are you here? What is it? What do you get out of this, working with our teams like this?
I think obviously your work is about real world data, real world practice. As a physician working in a large academic hospital, as you mentioned during the introduction, I spend a lot of time in evaluation in clinical trials. We do a lot of formal clinical research, but we know that clinical research is only about those very specific profile of patients, because they need to have enrollment criteria. They will be excluded to have some exclusion criteria, so it's still very limited, it does not correspond, obviously, to all patients in the real world. So I think real world plays an important role. I think regulatory agencies could understand this quite easily, and they tend to require in some files some reimbursement decisions, some real world data. So I think your work is very important about this. You can generate a massive number of important data during the different waves of studies you could run in the last few years. We could analyze thousands and thousands of patients.
And how does that, building that large volume of real world patient cases, in your view, how does those type of market research studies, does that contribute, and if so, in what way, to improving patient care?
So I think that it permits to define some overall trends for given prescribers. Once again, patient enrolled in our trials are very specific, highly selected, but in real world, it does not fit in all situations. So I think it permits to give some trends and natural evolution, and likelihood of different prescribers maybe to adopt more or less rapidly new agents. I was talking just before about the bispecifics. So I think this dynamic, you can have this dynamic aspect of the market, which don't have the clinical trials. Clinical trial permits to answer, obviously, to some specific questions. It's the only way to compare the different treatment between each other. So this is where it remains the cornerstone of the treatment algorithm evolution. But these dynamics and other trends of the real world, I think, gives additional insights into the dynamic of the markets, and to maybe to draw some overall trends. And I think this is a key point.
Yeah. Thank you. And just talking to other physicians, what would you say to them? Why would you encourage them to be involved in market research projects like this?
So I think this is valuable because it's a part to be involved in the overall progress we can make around the patients, to make understand a little bit about the evolution of the treatment paradigm, algorithm, landscape, etc., to help potentially regulatory agencies to make the decision for reimbursement process. We know that this can be some key points, something quite tough for which we need to wait sometimes many months, even years. And we can also generate some interesting data which can be presented in international meetings. And so what we have already done for EHA, for ASH, very important international meetings. We might maybe for the next step of our work of collaboration, maybe publish some of this data in key reviewed journals. Maybe it will be the logic, another step of our work together. So it permits to increase the amount of data and the level of knowledge around the dynamics.
And for other physicians, perhaps it's a way to improve their profile, and if they're participate in studies like this, potentially publish from it. And
potentially, yes, to be associated with those publications. And I think through also, because I do speak to some of those market research sometimes, me personally, and it permits maybe to take, more general perspective to think about what we are doing, why we are doing, and something. It permits to make us think about the treatment decision process, even if it's part of our routine practice. Yeah. But we do have, as you know, in French, we do have some RCP, tumor boards, those are potentially compulsory before making a treatment decision. But sometimes at the individual level, it permits also maybe to analyze a bit differently the reason why we could make any treatment decisions. So it's part of maybe of our personal work about the mindset we can have when we make any treatment decision.
I'm thinking now from the patient's perspective. Do you think there are ways that initiatives like what we've been doing here today, in what way do those have a downstream benefit for patients?
So I could have an experience thanks to some patient advocacy groups in the field of multiple myeloma. The group is called F3M. And I know that they could order some of the study to APLUSA directly regarding the impact of the disease, regarding the quality of life, regarding the impact in activities of daily living, which is not always very well assessed in pure clinical trials, even if the quality of life might be some secondary endpoints, that it's usually secondary and not usually studied in I would say, in depth. So I know there's a specific patient advocacy group that can take benefit from your work and to get really perspective into how the disease impact in patient lives, how they can improve that, and they can communicate about this. And during the end of the day, they organize in various region and academic centers some of your studies collaborated thanks to your work could have been presented in those in your biggest training days.
Interesting. And as we kind of wrap up, I want to think about, just looking back at what we've done so far today. It's been a busy morning. You've been sharing a lot of your perspectives, and you've been chatting with our teams over lunch as well, I know. Just so far, anything particularly stand out or particularly valuable for you personally?
So first of all, I always I had a good surprise about that. Let's say the dynamic, the enthusiasm, and the number of questions I could have, the level of involvement of each of you, especially on the topic of multiple myeloma. Even if I know this is not the only topic you are working on, and then after this overview, we spent a few time with some of your colleagues to try to refine and to try to optimize the questionnaire, which are going to be the backbone of the next questionnaire you're going to propose in the future, about which cytogenetic data to incorporate, which treatment sequence to incorporate, but in order to make specific questions more valuable, how to adapt it, to optimize it, and to be as far as possible from the routine practice, the different decision we make in our daily activities, and the key drivers on the perspective of the physician, and not only relying on standard data, clinical practice guidelines, which once again is a backbone for our treatment decision, but it's sometimes not very aligned on our perspectives and goals for the patients.
Yeah. Thank you. So you've spent most of the day so far with our teams, and as they reflect, as they go home at the end of the day and they reflect, what do you think is the most important thing you want them really to take away from this?
So, what a kind of take-home message or a kind of key takeaways. So I think that obviously you have to keep working on this. This is a very fast-moving therapeutic landscape. There is a lot of innovation, probably the hematologic malignancies, which have the highest level of innovation, probably with, as we mentioned earlier, the high number of new approvals. So we have to keep involved, to keep trying to understand better the key processes, the different stakeholders, the reason why we choose one treatment versus the another. This is important. Obviously, this is one of the messages I wanted to pass this morning will be to be aware of the ongoing clinical trial, the different results, if possible, to be able to attend international meetings where we tend to learn a lot of those different clinical trials. But I think there to keep in mind that there are two different parts. The first is the pure scientific data published in peer-reviewed journals and with communication in international meetings, but also the human who is behind that, the relative, the caregivers, the supporters, etc. Everything which is going to play a role in treatment decision, which is sometimes quite far. Some patients, as we mentioned during our discussion, some patients can sometimes be reluctant on proposing your treatment. Sometimes they can refuse on your treatment. So we always have to understand why they refuse, which are the perspectives, and how we can adapt as much as possible to their expectancies.
Yeah. And so just to close, if you've talked about a lot of the innovation, a lot of the change that you've seen in recent years, and a lot of things are coming through the pipeline. So if you had to summarize the future perspective of multiple myeloma treatment, I'm going to give you one sentence. How would you do that in terms of your expectations for the future, your hopes, your fears?
Expectations, my hopes. Probably, I hope we will keep having this level of innovation, investment of the pharmaceutical industry in the field of multiple myeloma to keep discovering new treatment options, new mechanisms of action, especially in patients who have been, for some of them, heavily pretreated. The unmet needs are still here. Even if the patient could gain very significant amount of survival. Fortunately, during the introduction, I told that when I studied my career and studying hematology, then overall survival was few years. Now we can expect up to 20 years over survival. This is unprecedented. So I hope that one day, if possible, we could talk about if you cure multiple myeloma, or if it's not possible, the perspective to improve survival in order to obtain the equivalent life expectancy for our patient, as compared to the general population.
Fantastic.
I'm not reading it.
Dr. Blin, on that inspirational note, let's draw the interview to a close. Thank you so much once again for spending time with us. It's been a pleasure. Thank you so much.
Same for you. Same for you. Take care. Bye.